Can you see my live streaming screen or just my slide still?
Your slide.
Great. All right. I think we'll get started here today. Everybody, please remember to record your attendance by texting 4960 to the usual number. Give everybody a minute to do that. Today we've got a all-star lineup, doubleheader cerebrovascular with Shram Majidi starting off. As you know, he's assistant professor in neurosurgery, neurology, and radiology, and he's the director of cerebrovascular services at Mount Sinai, Brooklyn. He's going to be talking to us today about the initial U.S. experience with Stentrode. And as many of you know, this is a unique and game-changing device developed by Tom Oxley and his colleagues at Synchron. And Mount Sinai is one of two centers in the COMMAND trial. And Shram Majidi has placed these devices and is going to give us an update on his experience and the early results of the study. And then following, we'll have Tomoyoshi Shigematsu, assistant professor in neurosurgery, neurology, and radiology, giving us a talk on endovascular treatment of intracranial wide neck bifurcation aneurysms, one of the few types of aneurysms that we still debate actively what the best management is. So looking forward to both of these very exciting talks, and I'll start off by passing off to Shram.
Thank you very much. Good morning, everyone. I'm gonna start sharing my screen here. Okay. Do you see my screen?
Yep, it's not in presentation mode yet, but we can see it.
Okay, so a year ago, Tom Oxley presented their experience, his journey of developing this Stentrode with over a decade of work, and their initial experience in Australia, which was the beginning of COMMAND trial here in the US. I thought now that we are halfway done with COMMAND trial, it's probably a good time to give an update on the status of our US experience here. I have no relevant disclosure for this talk. So just a little background: over 5 million people live in the United States with severe paralysis, with various causes, including stroke, demyelinating diseases like MS or the Vick's disease, or neurodegenerative diseases such as ALS, muscular dystrophy, or trauma like spinal cord injury, or peripheral neuromuscular diseases such as myasthenia gravis. The subset of these patients, the command center in the brain, the brain cortex, is intact and able to generate signals. However, there is a disconnect between the command center and the distal organ neuromuscular system. So the idea of brain-computer interface is just to obtain the neural activity in the brain and decode them, and then translate them to some sort of output, either usage of digital devices or using artificial prosthetic arms. If we go quickly to the history of brain-computer interface, we first got in 1929, we got the first human record of EEG, but then a computer scientist and physicist in UCLA, Jacques Vidal, was the first one who started this idea of brain-computer interface, essentially starting of the concept of obtaining the signals directly from the brain and connecting it to computer. But in 2006, this was the very first report of the first patient, which it was implanted with penetrating Utah array of electrode to control digital devices and to operate a prosthetic hand. And then in 2016, the group in Mass General, they actually had their first surface electrode that they implanted in a patient with ALS, which was a fully implanted system with craniotomy with 16 channels, which enabled the patient to independently utilize digital devices. This was the very first example of independent use of intracortical BCI at home, and that was the only mean of communication for the patient. And in 2021, the UCSF group, as you see here, they had essentially, they implanted like high frequency electrodes in a patient with severe dysarthria, which was a patient was a locked-in patient, unable to generate any work. So they implanted this surface electrode over the speech area, and over the course of 6 months of training, patient was able to they were able to decode words and sentences directly from the cortex to generate speech with a very high accuracy and relatively good speed, 12.5 correct word per minute, which was pretty breakthrough. However, then the concept of endovascular brain-computer interface started by the work that Dr. Oxley and his team started in Australia more than a decade ago, and then continued over the time. So until they developed this stentrode, which has three components. So there's a stent which carries the 16 electrodes mounted on it, and then connected to a lead wire, which is a 75 centimeter lead wire. You implant the stent within the superior sagittal sinus next to the motor cortex through the IJ axis, and there is an IRTU or internal receiver that is being placed in the subcutaneous subclavicular pocket, and then that obtain the signals and transfer to a outside computer, which will be decoded and will be used to operate digital devices. So their initial human trial in Australia was switch trial that they enrolled 4 patients, and a few years ago they published their safety results for patients successfully implanted. There was no safety concern, there was no adverse event, and all patients did very well with the all outcome measure that was defined in the studies, with no evidence of thromboembolism or occlusion of the venous structures. And you see here, this is the initial and follow-up CTV for their one of their patients that is showing stentrode in superior sagittal sinus at 3 months and 12 months with no evidence of occlusion in the cerebral venous sinus structure. And here is one of the patient from Australian trial trying to utilize stentrode to operate a home device and turning on the lights. And here we see that two of their subjects are communicating with each other by utilizing central device. So then in July 2021, FDA provided IDE approval for Stentro to be used within clinical trial in the United States, which was the beginning of COMMAND trial, which is an early feasibility study of safety of using endovascular BCI Stentro in patients with severe quadriparesis. This study includes 6 subjects across 2 sites here at Sinai and also UPMC in Pittsburgh. Study includes a total of 12 months follow-up after implantation, and the primary endpoints are device-related serious adverse events within 12 months post-implant, and also target vessel patency, which will be assessed at 3 months and 12 months post-implantation by follow-up CT venogram. Also, there's a pre-specified secondary outcome, which was initial efficacy, which is a digital device control and patient questionnaire and caregiver diary in terms of how they did with the device. The eligibility criteria for COMMAND is age 21 to 75, severe paralysis in both arms and legs, English-speaking patient. Patient should be able to come to one of these 2 centers, either in New York City or Pittsburgh, and should be able to provide consent, and also has a caregiver who can assist during the training sessions after implantation. There's a clinical screening that we perform. Patients should be unable to tap the screen of a smartphone if you hold in front of the body, and also unable to do finger tap or very limited finger tap in 10 seconds as a screening study. So now we are actively enrolling. We have identified 4 patients. 3 patients has been already implanted. I will take you through the process for pre-implantation and the procedure itself. The pre-implantation planning include MR venogram that we obtained to study the venous structure of the brain to ascertain patency of superior sagittal sinus and bilateral transverse sinuses. So here you see in our patient, there was a dominant right transverse sinus, so we decided to go through the right side for our first patient. Pre-implant planning also include structural MRI, which we use to identify precentral gyrus because we plan to deploy the stent next to the precentral gyrus. Here you see that we use this T1 postcon to identify the precentral gyrus. We identify the posterior border of the precentral gyrus and put this yellow marker there, right at the junction of superior sagittal sinus. And then the working length of the stent is 20 millimeters. So therefore we draw a line through the superior sagittal sinus forward and then mark it at 20 millimeter length. And then there is a fluoro marker 40 millimeter proximally in the device. So then we draw another line from this distal marker back 40 millimeter here and put this red marker there. So now we have 3 markers here that we save, and this we use that to co-register this to a live angiography, then which will be used as a roadmap and markers for precise delivery of the stent next to the motor cortex. So this is our setup. So we prep the right neck area for IJ access and right chest area for the subclavicular pocket formation, and also right radial axis for control arterial angiogram. So in right IJ, we put a short 6 French sheet, and then with a 6 French guide catheter, we access superior sagittal sinus while we are using the roadmap obtained from the control diagnostic arterial angiogram. Here you see that now we have co-registered those 3 markers that we had obtained from the structural MRI here in our live angiography. Now I can tell where the motor cortex is based on these 3 markers that we have from our MRI. Here we have the guide catheter right at the superior sagittal sinus where the motor cortex is. And you see that we're advancing the preloaded device, which is within a 4 French delivery catheter. This is the centrode coming up inside the guide catheter, right, going to the target area. So again, here we are using the co-registration. We have the 3 markers again here, so we can tell where the motor cortex is. So now we are gonna deploy the stent right at the desired location. Here we are unsheathing the stent and opening it in the target area in superior sagittal sinus. So the current version of the stent doesn't have the fluoromarker on its length. There's only this fluoromarker right 40 millimeter distal to the tip of the stent that we use as our marker just to make sure stent is not falling back and it is deploying in the intended place. So here the stent is fully deployed. Again, the 40 millimeter markers here. This is the motor cortex. The stent is extending from here all the way down here. And this is the delivery catheter and a more proximal area and also the guide catheter. So the next step is going to be to remove delivery catheter and guide catheter all the way out. Again, under careful fluoroscopic visualization, because we don't want the stent come back to more proximal area or even inadvertently push forward to more distal location. So that's why these 3 markers are very important in this process. We are exchanging out the guide catheter at this point, coming out from the transverse sinus and sigmoid while maintaining the visualization of the device. Now the guide catheter is completely out. Now we have the extension wire and the lead wire, which is extending out from the axis, IJ axis. Here is our post-implantation 3D, which is showing the stent road device and the lead wire in the superior sagittal sinus and with no untoward event. And this is our 3D reconstruction, which is showing that the stent road is fully deployed in a natural position in the desired area. So the next step here, as you see here, this is our IJ axis side. The lead wire is coming out from the axis side. We hold pressure to achieve hemostasis there. And the next step is to create a subclavicular pocket for the receiver, and then to tunnel the wire into the pocket. These patients are on dual antiplatelet to prevent clot formation within the stent in acute phase. That's why they might have a little extra bleeding during the pocket formation. So we use bipolar and make sure we achieve good hemostasis during the pocket formation. And here, after creating the pocket, you tunnel the wire into the pocket and then close it. So the next step is just to plug the lead into the telemetry unit and to ascertain the patency of the system. So here are the initial neural signal that we receive from brain, so just to make sure the system is patent and fully connected. And this is a post-op X-ray that we obtain at the end of the procedure, which is showing the stent rod and the lead wire extending all the way from superior sagittal sinus down to the IJ axis and then into the pocket in the right chest area. Both our patients here at Sinai, they stayed in the hospital for 48 hours, and then we discharged them home on dual antiplatelet therapy for 3 months. So the next step for the patients are to start training with our engineering. When they train them on to attempt to tap the foot or wave hand or tap fingers, as you know, they are paralyzed, so they cannot do it, but they attempt to do it, and each of these attempts, they create specific signal, reproducible signal that was used to decode and connect each of them to certain computer functions, such as right click, left click, or enter, and then eventually patient will be able to operate the digital device with this decoded signals. So again, four patient has been enrolled, 3 participants already implanted, and the first patient is now 4 months post-implant. There has been no adverse events reported during or following the procedure. The activation of the device achieved on time, and there was a successful switch control achievement during the first session, and the first patient is now able to utilize the device, search the internet, send message, report his symptoms to the caregiver, and control the tablets and personal phone. This is our first patient here at Sinai, who is utilizing stent rod device to report his symptoms, pain, to his caregiver. So where the pain is and the nature of the pain, and the scale of the pain. Pretty impressive, just using the device in combination with eye tracking to report this.
That's exactly what we were. Oh,
Okay, so in summary here, we report successful implantation of the first three endovascular BCI system here in the United States, two of them here at Mount Sinai, and the third one at UPMC. So minimally invasive endovascular BCI has potential to restore neural signal transmission to control digital devices, and perhaps improve patients' level of independence and quality of life by enhancing their communication with friends and loved ones, and also enabling them to operate digital devices. However, significant challenges must be crossed before this technology reaches daily clinical use. We are in process of understanding different aspects of this now new procedure in endovascular field in terms of pocket formation, tunneling, and potential complication related to that, or some potential issues and complication which can occur down the road related to this new lead wire, which is extending from superior sagittal sinus down to the chest, whether it can be in-stent stenosis or thrombosis or lead wire infection, hardware failure, or lead wire fractures. These are the things that we will learn during the process of this trial and the next pivotal trial. Nevertheless, there is now no question that we are at the beginning of a new era. This is a skull X-ray report from our first patient. Based on protocol, we have a skull X-ray that needs to obtain after implantation next morning. So this is a report from an on-call radiologist, which was not part of the study. But when I read it, it was interesting that the impression was, okay, interval placement of right transvenous stent road BCI device, no kink or discontinuity. I was like, oh, wow, this is really happening. This is now, stent road BCI is now in radiology templates. So it's like they're reporting EVD or other usual clinical devices. So pretty cool. I think that's all I have for today. Happy to take questions.
Sharam, in the chat, Brian asked some questions. Can you see that?
I'm gonna see. Yes, yeah. So yeah, Dr. Capel had two questions. First is, what is your plan should a patient develop a hardware infection? And the second one, what is the plan should a patient develop a lead fracture? Great question for infection. If really it is related to the device and the hardware, we have to pull the device out. We take it very seriously. We have a very rigorous antibiotic regimen for during the implantation, for pocket formation and tunneling. So far, we haven't had any issue in this 6 implantation overall. But if this happens, I think that's going to be the plan. And in terms of lead wire fracture, the wire is very soft, and it's really, it's not kinkable, and the way it traveled through the IJ and down to the pocket, the risk of fracture is low. However, if it happens, if it discontinues from the, if it impact the continuity of the system and its functionality, then it's going to have to stay there and stay non-functional.
Dr.
And
Capel, I
the
have a
next
follow-up question. Oh, sorry.
is, can the device be removed even? Well, yeah, well, longer it stays, obviously the removal is going to be a challenge, especially after endothelialization. It can damage the venous structure. That will not be easy.
Hey, Shram, it's Alex. I have a question. Great talk, really inspiring, exciting stuff. You guys are a couple patients in. More of a technical question about the IPG. So does it stay on mode, kind of like a DBS or other functional IPG would, or is it in like a standby mode, say when the patient's sleeping to preserve battery, or does it just persistently stay in this on mode 24 hours a day?
It is always on mode, but in order to receive the signal, there is an external part that the patient puts on top of it over the chest to receive the signal.
Okay, thanks.
Thank you.
Great talk, Shahram. I just had a question about the training of the algorithm once the stentrode is implanted. So you said that it's having to learn the commands and the signals to then work on inferring what is a click, what is a right click or a mouse movement. What is how long does it take the training algorithm to then work through? Like, is there a test data set that it does on its own signal to confer against? How is that working?
Yeah, so we usually wait 3 weeks for the chest to heal, and then at 3-week marks we start the training. Usually, so far the experiences usually at 6 weeks, something between 3 to 6 weeks period, patients we are able to consistently and reliably and reproducibly receive signal. And then in the course of 4 to 8 weeks, our patients are able to operate that and understand how to do this simple commands like right click, left click. So our first patient at 3.5 months out, he was able to perform those tasks.
Thank you.
Sure.
Anyone else have any questions for Dr. Majidi?
Is Tomo next?
Yes. Tomo, Dr. Kellner asked me to just let you know that as soon as we're ready, you can start presenting your slides.
Thank you. Then we'll do.
Let's stop sharing. Thank you.
Yeah. Very good talk, Shahram. It's fascinating. All right, so I'm gonna share screen and then start this slide. Hi, good morning. This is I'm Tomoyoshi Shigematsu. I'm one of the neurosurgery trained endovascular neurosurgeon in the Cerebrovascular Center in Sinai. Today I just want to talk about the endovascular treatment for the wide neck bifurcation aneurysm. and where we are right now. Basically, I want to talk about that part. So I don't have any disclosure. I don't have any conflicts to any devices. So about the treatment of ruptured intracranial aneurysm, there is good evidence, but the evidence, it came out around 2002, and Barrow followed up like after that, 2010. But the first evidence we got is from ISAT, the International Subarachnoid Aneurysm Trial. They enrolled more than 2,000 patients, and then they randomized to the subarachnoid patient, and then they randomized the aneurysm treatment to the neurosurgical clipping or the endovascular coiling. And but interestingly, they enrolled, they screened more than 9,000 patients, and they only enrolled 2,000. That's maybe a little bit tricky part. So I'm thinking that maybe these wide bifurcation aneurysm was not enrolled because it was not considered as a treatable in either of the modalities. But anyway, so thinking those concern, Barrow started their trial, like more realist, real life or real clinical life, closer to real clinical life. They enrolled the consequent subarachnoid cases, and then they put between the 2003 March and 2007, they screened the 5,000 patients, 500 patients, and they put the first one in the endovascular, and then the next one goes to the surgical, and then the next one goes to the endovascular, and they assign the patient. So it's not a true randomized trial, but they assigned like real patients in both arms. So, and they found that I'm gonna show you and we're gonna review the result again, but the ISAT, including a long-term. So in patients with ruptured intracranial aneurysm, it's like suitable for both treatment, endovascular coiling and clipping. And endovascular coiling is more likely to result in independent survival at 1 year. So 1 year independent survival, they put that as a primary outcome. And then it was better than the neurosurgical clipping. And the surgical survival benefit as well. It's lasts for 7 years. So long-term was promising as well, if the patient is suitable for either of the treatment. I think that's the key point. But here, as you see, less modifier ranking 6 or even 3 to 6, relative risk reduction rate is to 23.9. As I said recently in the Science, and the absolute risk reduction is 7.4%, and it was significant. And following the Brad, and now here I'm just showing the 1 year results. 1 year after the treatment, endovascular, the patient who were assigned to the endovascular surgery had better outcome in 1 year. That means they tried or they considered endovascular treatment, and then some patient may needed to go to the clipping, but I think it's okay because the strategy, considering the coiling, and then if it doesn't work, then consider clipping, is very reasonable way to think or manage the patient. And then they did that way. They had a good result in 1 year in the endovascular assigned patient, and they have a 10 years follow up. They published a 10 years follow up in 2020, and the long term, actually long term did not show difference in between the clipping group and the coiling group, but the survival rate lasted. Interestingly, interesting that we need to consider is, of course, the coiling group cannot achieve or cannot achieve the complete occlusion or may need a treatment in the future. But as long as how I take is, as long as we follow the patient well, then we are able to make the patient have a good life after even having the subarachnoid hemorrhage. So this was the evidence or the clinical trial outcome. But as I said, the first ISAT came out in 2002 in 1 year, and then long term in 2005. So what were they doing in those days? But first, embolization, before we started how we got the detachable coil, there was only option using balloon. So detachable balloon was the first embolic device to close the aneurysm. It was, so 1980s, we only see this balloon, detachable balloon, embolization using a detachable balloon. It looked good, but the indication was very limited, and the long term was not so good. And this was a milestone paper that Dr. Guglielmi published or developed. They developed the electronic detachable coil, and then it came out in 1991. But if you take a look at this paper, they of course they used that device before publishing the paper. So the device was used in human first in 1990. And interestingly, they didn't focus. The focus for this device was not more like closing the aneurysm, but more in promoting the thrombosis in the aneurysm by putting the electric current, like running the electricity inside the aneurysm, so that it can initiate the thrombosis inside the aneurysm, and then eventually close the aneurysm. So as you see here, the abstract intra-aneurysmal thrombosis was then initiated by applying a low positive direct electric current to the delivery guide wire. So, but again, afterwards, we now realize that the electricity is not as important, but this concept having the detachable coil in the aneurysm, and we can detach from the delivery wire. This concept was the big thing to start for aneurysm embolization. So again, the Guglielmi detachable coil. This is the first detachable coil. The coil introduced in 1991 and first used in 1990. First, again, the detachable coil is the most important. It's made in platinum, and the coil has the shape. It's coil. It's a helical coil. And again, initially thrombosis was considered to be it's very important. But afterwards, after this was introduced, they had more cases, and then a lot of things have been realized. Like before 2000, the coils realized that the coils do not completely fill the aneurysm. Of course, there is a gap between the coils and coils, and the process of the thrombosis still required, but not with with something else other than the electricity. So those things were started to be considering, and a lot of devices have been developed. So because of there's a gap, we figured out that we need to place the coils in the aneurysm as tight as possible. And not just at the tip of the aneurysm, we need to close the neck, but mainly, of course, to block the blood flow getting into the aneurysm. So place the coils, especially at the neck, tightly, or close the aneurysm entirely equally. We found that those things are important. At the same time, is there anything that can promote the process of the thrombosis? Then in 1990s or 2000s, bioactive coils were developed. Like these bioactive coils, it's like I just wanted to show us that so I haven't seen long time. I don't know if it's still available in the United States. This is called matrix coil. The coils are covered. It's coated with the PGLA, which is the same as the bicural sutures we use in the surgery and in the OR. They use it. They put that onto the coil, and then that promotes the thrombosis. Or the hydrocoils with the hydrogel onto the coil or inside the coil to fill the gap between the coils even after the coiling, so it can close the aneurysm getting closed even as progressively after the coiling. But those things are not that popular at current era though. But and the coil embolization before the 2000. So how can we make the aneurysm patch tightly? How we can spread the coils all over the entire aneurysm? So a lot of company came out and then they made a lot of different shape of the coil. So this shape of coils act differently than this shape of coils, and then we need to know the difference, and then to choose one device to fill up the aneurysm nicely. There's so many different kinds of coils, type of the shape, as well as the length of the coils and the softness of the coil. So selection got we have so many varieties. And as a process of embolizing the coil, getting more cases, we found that there's a lot of publication saying that the size of the neck is important, and it is important to know how much you embolize the aneurysm. So size of the neck is important if the aneurysm has the wide neck, the big neck, and these words dome to neck ratio, or the neck size, dome to neck ratio, or the aspect ratio. These terminology comes into a lot of clinical trials or trials for the new devices. These wide neck aneurysm is considered to need adjunctive technique or difficult to treat endovascularly. And that also another thing, the packing density means how much you place the coil inside the aneurysm. Usually we end up 20 is too less, but around 30%, 35%. So as you see, 70% is not filled. There's a lot of gap between the coils, but it's still the coiling works, and it is considered the higher the better. The higher packing density, the better, and especially you need to pack the area around the neck. These things became obvious, or we found that these things are important. So, as I said, the wide neck aneurysm is difficult to treat, so it was not considered as a treatable aneurysm at the beginning, probably. in 1990s or early 2000s. So but still, there's a big development, and then it's possible. Now it's possible. But why it's difficult? So since the aneurysm coiling was introduced, it was considered as challenging. It's not difficult, but it's challenging for several reasons. So if the neck is wide, it's very difficult to stabilize the coils inside the aneurysm sac, and it comes out to the neck, and that can cause thrombotic ischemic complication. That's number one. Or the wide neck bifurcation frequently have branches coming out from the aneurysm. It looks like the branches are coming out from the aneurysm, so we need to save those branches. And we found that the wide neck, they had been treated, and then they found that the recanalization or recurrence of the aneurysm rate is higher than the narrow neck aneurysm. So thinking those challenges, there's a good review already in the 2016, but about the vascular treatment. The first developed was the balloon assist, temporary balloon assist, aneurysm treatment, balloon assist coil embolization. So we can bring two catheter, one catheter inside the aneurysm to place the coil, and then the second catheter inside the parent vessel, and with the balloon. So we can inflate the balloon tentatively, or just while we're placing the coil. It's not going to be the permanent, and then deflate the balloon eventually and take the balloon out. That's helpful because then we have the 3D shaped coils that we know that they will stay in the coil once we have the coil inside the aneurysm. But it's not, again, it's not like a permanent. So once we deflate the balloon, the coil can possibly come out. So we have to make sure. So it's not 100% like a perfect solution. And for the bifurcation aneurysm, it's not easy to cover the neck completely. There's a branches on the other side, so we need a very compliant balloon or two balloons, or like the procedure gets more complicated. So it's not a perfect solution, and it still had a relatively high recanalization rate. And afterwards, like early 2000s, the stent came into our field. So this is just a little scheme I draw in the single stent assist coiling for the bifurcation aneurysm. This is the most popular thing that we're doing currently. But for the bifurcation, it's not. The one stent does not cover the other's bifurcation, the branch. So there's always a chance that the coils can come out and block the other branch. But you see, to narrow the neck, by the stent makes the chance of the coil coming out less. So that's one option. And if you really want to cover both branches, the wire stent became one of the technique. And there's another way that we call it waffle cone technique. These like advanced technique has developed, but we know that there's been a lot published, but we know that these techniques are not also still not 100% good, and then they have as the procedure gets more complicated, the more complication, especially ischemic or even like hemorrhagic complication during the procedure are being observed. So high complication rate, but still occlusion rate is good. And okay. So for the bifurcation aneurysm, like for the waffle cone, like a waffle cone technique, they develop a new device just for the waffle cone technique, because this is not available in the United States, but like this pulsar rider just cover the neck and the branch and then place the like these interluminal devices has been became available. We can use it. So in good situation, we've been using these kind of things. So as these four technologies that I showed this here is interluminal devices. So it stays inside the parent vessel. So interluminal devices require for the bifurcation aneurysms, we usually don't do the flow diverters. I'm not going to talk much about the flow diverter because we have to close the other branch. So not much used. It is used, but not much used. Interluminal devices require the use of dual antiplatelet therapy. This is a big thing for these interluminal devices to prevent ischemic complication and facilitate the sterilization over the devices without causing the parent vessel thrombosis or occlusion. So So we usually can't use the dual antiplatelet therapy for the acute rupture cases. That's a big concern. So that's why, especially the rupture cases, it's challenging to treat the aneurysm with endovascular technique. So now, different concepts came out after the flow diverter, actually. So now we have the intrasaccular flow disruption. This is a new concept of putting the flow diverter inside the aneurysm. This came out. Especially the web is most popular and famous, I think. So flow disruption is a new endovascular approach, which involves placement of the intrasaccular device like this. And it blocks, but it doesn't completely block because it's a mesh. It's a woven mesh device and they focus on the neck. So this cover the neck and then block the flow inside the aneurysm. So it will facilitate the endosterilization at the neck, and then the aneurysm get closed in a couple of months or 1 year or something like that. So web is now available in the United States, and we have a lot of evidence already published. It's with a good result. And for another, like for 4 or 5 more devices they're trying to come out into the market. Like this case, got this picture from their publications, but this is how the web device looks like in the clinical field. In Sinai, we have a lot of cases as well. So it covers the neck, even though this wide neck aneurysm, it covers the neck and then keep the branches open. And eventually it goes away. The aneurysm goes away. So for this web device, originally they published the effect and the safety in 2017. And in the US, we have a good trial as well, and it was published in 2019. And even recently, the first publication had a follow-up publication, and the 5-year clinical outcome is super good. What's good about this device is we place the device in the aneurysm. That's it. So the procedure time is going to be very short. And I think it's a very soft device and fast. So So far, I believe there is no interprocedural rupture of the aneurysm while placing this device into the aneurysm. So that's very fascinating. But so what's the issue, or what's the challenge in using those kind of devices? So it doesn't fit to the old aneurysm. The shape of the aneurysm I think is very important. It needs to cover the neck very nicely. So the shape of the web, especially the web device, it's not. So that's why they're trying to develop more different shape of the devices to well cover the neck. But yeah, so we have to get the image or get the idea of the aneurysm first, and then think about if this device is available or not, or feasible or not. And good result, that is true, but it's also true that compared to the stent assist coiling was published as around 90%, 92% of complete occlusion rate in the follow-up more than 1 year. Compared to that, well, web device, the most recent web device outcome was around 80% complete occlusion. So 15 to 20% to retreatment rate. That was what we just, I think it's good because we can just retreat it. And so the follow-up is important. So I just showed you two ways of the treatment for the wide neck bifurcation aneurysm. One, it was the intraluminal devices as listing coiling, but the DAPT using the dual antiplatelet therapy is very big thing that we need to consider, and it's contraindicated or not indicated for the subarachnoid hemorrhage acute phase. And intrasaccular field disruption, it is actually, there are some publications using in the ruptured aneurysm, and it is indicated for that ruptured aneurysm. It's been working, so we can use it. But as I said, we need to figure out if the aneurysm shape is good, and the morphology. We need to check the morphology nicely, and you'll need a little bit more experience, like the learning curve, for it to actually place the device. But can we take the good part of these two modalities? So can we use it intrasaccular, but like using the classic coiling technique, because we are so used to it. We have a good evidence of the coiling, long-term evidence already that the coiling works. So if there's a device or there's a technique that we can use, not the intraluminal but intrasaccular, so that we don't need to adapt, so that we can use the subarachnoid hemorrhage, and we can still use our basic technique just to place the classic coiling technique with the device. And if the intrasaccular device can cover the neck nicely, it's as the flow disruption, then it will help to prevent the reconsolidation. So the new device. So I think this is and I was wondering why we didn't have it, but now we kind of have the newer devices called Nautilus from Endostream Medical Israel. It's almost like a coil. It's just a coil, but it looks like this. It looks a coil. It looks like tornado shape here, and it's nicely covered the neck like this. So and it's a little bit stiffer than normal foil. So if we cover this. So this device is to develop to cover this neck of like this here, and then in with a normal coiling technique, and then we can place the normal as like a classic coils to fill the aneurysm, so that we can nicely coil and hack the coil safely, and we don't need a antiplatelet afterwards. So this is a new device we has been developed, and this is a concept we placed here, and then afterwards we get into the aneurysm with a thickened microcatheter and then packing, and then eventually we detach both devices and leave them inside the aneurysm. This is microscopic, and this is how it looks like clinically in the 3D picture. Now, this has a CE mark, so it's been used in the Europe already for a handful of cases, and the results seems to like it's not that much different from the coiling. So the outcome must be promising, and it is so far. And additionally to that, it's thicker and it covers the neck tighter than the normal coils, and the results is a lot actually the better. Even if we ended up with, even if they end up in the not tight packing of the aneurysm, eventually it gets thrombosed. They're getting that kind of good outcome as well. So this device is getting approved. Fortunately, I had the opportunity to join the treatment. Actually, it was in Japan for the first in man cases. Like these kind of this good, like typical wide neck bifurcation aneurysm in the vascular terminus. We use in the first human case, we use the Nautilus at the neck and then feel the coil. This was at the end, but in 6 months follow-up, the aneurysm completely went away. And then it's been good for 3 years in the follow-up. And actually, we already have 4 years follow-up, clinical follow-up. So it was like a few years ago. I had the opportunity to join these cases. And finally, it is getting into, they're trying to bring this into the US market as well. I think it's going to be very helpful. And now they're starting the trial called Tornado US. Actually, it has kicked off last week. So the Tornado US it's treatment of ruptured. So we collect the ruptured aneurysm and then treat with Nautilus assist coiling. And these are the inclusion criteria. Sorry, I didn't. These are the indications. So the aneurysm has to be wide neck, of course, and then big. And the design is much center, open label, prospective single arm blind successor. Yeah. So the primary endpoint is basically, as I say, we have to have the FDA approved. So this is the safety. They focus on the safety. So the primary endpoint is the risk of any non-accidental cause or any major ipsilateral events. Thankfully, last week we kicked off, so hopefully we can get first case. I will be happy if I can join to the first case in the human and the first case in the United States. So I'm looking forward to it. So this was my talk. I hope this will help. If you have any questions, I'm happy to take it.
Tomo, that was great. It was a really cool presentation. It was a full survey of what we're doing and where it's going. Happy to take any questions from the team. Anyone wondering?
Tomo, thank you so much for the talk. It was great. I just wanted to ask, for ruptured versus unruptured management of these wide neck aneurysms, obviously, there's different strategies that might be necessary if the wide neck aneurysm is ruptured. So, what considerations would you have for providers looking to treat the ruptured wide necks specifically over unruptured?
Ruptured aneurysm is so, as I said, the device is going to be limited. So, and we have to think about what kind of devices which devices need the antiplatelet therapy afterwards. So, and those devices usually get eliminated for consideration of the treatment, right? So, and at the same time, as a neurosurgery trained physicians, we can consider about the surgical clipping way to treat this aneurysm. So more likely to go to, in myself actually, more likely to go to clipping than if the aneurysm is wide neck. But still, once we get these kind of, like especially this Nautilus device, the aneurysm treatment will be easier with the known technology that we used to use and then we have already. So we can just use this Nautilus device as like additional coil, and then just coil the aneurysm. It works. So we have to try to keep up with the newer technology or what the device is available in the United States. Yeah.
Awesome. Thank you.
Hi, Dr.
Does anyone else
Shigematsu.
have-
Yeah, I had a quick question, Dr. Shigematsu. Thanks so much for your talk. About the Nautilus device, I was wondering whether the diameter of the Nautilus needs to be sort of adjusted depending on the measured diameter of the wide neck, and if so, how's that done? Just I think you mentioned that the material is stiffer than sort of other devices.
It's a little bit stiffer than the normal coils, I would say. So it's not as stiff as like a actual like stiff stents or those things. So it's safe to place in the aneurysm. So it's normal coil, and there are a certain lineups. So they have 5 millimeters Nautilus device and 6 millimeters, 7 millimeters. So we can choose the proper device measured by measuring the initial angiogram neck. Yeah.
Great, thank you.
Any other questions for Dr. Shigematsu? All right. Thank you, Tomo. That was great.
All right.
Thanks, everyone.
Thank you.
Thank you all.
Thank you.